An excoriated area of stomach or intestinal mucosa caused principally by digestive action of gastric juice or upper small intestinal secretion. It is frequently occurs along the lesser curvature of antral end of the stomach. If peptic ulcer is found in stomach, it is called gastric ulcer, and if found in duodenum, it is called as duodenal ulcer. Mucosal protective mechanism. The autodigestion of mucosa is mainly prevented by the mucosal barrier. The gastric mucosal epithelium is covered by mucus. The mucus is primarily made up of thick insoluble variety and does not flow or move easily. So this is called unstirred layer. But some soluble mucus is also present. The acid and pepsin, after being secreted by the gastric glands, reach the lumen to come in contact with the food. But it cannot return to come in contact with the mucosal epithelium because of the mucus of the unstirred layer, which acts as a barrier. Bicarbonate secretion. Between the mucus and the epithelium, some bicarbonate rich fluid is present. Within the lumen, the pH is low, that is about 2.5, and hence pepsin is very active, that it can easily digest the protein. But near the epithelium, because of the presence of bicarbonate ions, the pH is high, so that the pepsin becomes inactive. This bicarbonate cannot move towards the lumen because of the presence of unstirred layer. Epithelial barrier. The intercellular tight junctions provide a barrier to back diffusion of H plus ion. And trifoil peptides, the trifoil peptides in the mucosa of stomach are acid resistant and protect stomach. Whereas prostaglandins E2 can help in the synthesis of mucus and formation of new mucosal cells. If there is an injury in the gastric mucosa, the dead cells can be speedily replaced. So this is the diagram showing the mucosal barrier. This is the epithelial layer of the gastric mucosa, and this layer is the pH is active about 6 because of the presence of bicarbonate, and pepsin is inactive in this particular layer, which is called as bicarbonate layer. So then you have a mucus layer, and then you have acid and pepsin mixture, and above which you have a gastric lumen containing acid and pepsin. Here the pH is around 2.5, and pepsin is very active in this particular layer. And the epithelial cells, they form the tight junction between the epithelial cells, and nothing can pass through these tight junctions. Causes of peptic ulcer. The usual cause of peptic ulceration is an imbalance between the rate of secretion of gastric juice and degree of protection offered by. It is mainly the gastroduodenal mucosal barrier and the neutralization of the gastric acid by bicarbonates. Then the bacterial infection such as Helicobacter pylori breaks down the mucus barrier. That is another cause. In long-term use of non-steroidal anti-inflammatory drugs like NSAIDs and like aspirins, they decrease the mucus and bicarbonate secretion, and since they inhibit the production of because they inhibit the production of prostaglandins, and hence they can decrease the mucus and bicarbonate secretion. The smoking alcohol can disrupt mucosal barrier. Reflux of gastric contents into the esophagus and duodenal content into the stomach can lead to ulceration. Excess of secretion of gastric juices, which may be due to the increased parietal cell mass, and increased sensitivity for the sensory stimuli, and the Zollinger-Ellison syndrome, which is seen in a patients with gastrinomas, that is the tumor which are secreting gastrin, and these tumors can occur in stomach, duodenum, and mostly in pancreas. Gastrin causes prolonged hypersecretion of acid and severe ulcers are produced. And sometimes poor blood supply can cause ulcerations. So these are the difference between duodenal ulcer and the gastric ulcer. Duodenal ulcer, they are seen in the second part of the duodenum, whereas gastric ulcers are the more common in the curvature of the stomach, especially at the incisura angularis. Duodenal ulcers are more common compared to the gastric ulcer, and the incidence is more in younger group, whereas gastric ulcer, they are in the old elderly group. The duodenal ulcers more common in case of males. It is gastric ulcer is equal in both the sexes. Duodenal ulcer are not associated with any malignancy, whereas chronic gastric ulcers, they are associated with malignancies. The duodenal ulcer has higher gastric acid secretion because of the back diffusion of H plus ion, whereas you can see the normal levels of gastric acid secretion in gastric ulcer. Duodenal ulcer are relieved by the food and antacids, whereas the food doesn't uh, give relief, rather food aggravates the pain in case of gastric ulcer. Complications are less with duodenal ulcers. Complications are severe with gastric ulcer. Duodenal ulcers are superficial and small in size, whereas gastric ulcers are deep-seated, they are larger in size. Some of the complications of peptic ulceration are perforations. Ulcer burrows through the coats of the stomach that leads to gastric or duodenal lumen, which now communicates through this perforation with a peritoneal cavity. And there can be hemorrhage from this ulcer. Physiological treatment. So usually they are treated with antacids to neutralize the acid. The use of antibiotics along with the other agents to kill the infectious bacteria. Administration of acid suppressants drugs such as cimetidine, ranitidine, both block histamine receptors on parietal cells. Whereas omeprazole, it is going to block the hydrogen potassium ATPase pump, or also called as proton pump. The NSAIDs induced ulcers can be treated by stopping the use of NSAIDs or by treatment with prostaglandin agonist such as a misoprostol. Gastrinomas can be removed surgically, and sometimes vagotomy and partial gastrectomy can help in the treatment. The coating agents of the mucosa, like drugs like sucralfate, and sometimes the atropine, which is the anticoagulatant